Hi, I'm Justine,
And I'm Sarah Levon.
and we are so glad you're here.
We believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every single person and patient you touch.
We want to inspire you with resources, education, and stories to support you to live your absolute best life, both in and outside of work.
But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together.
By nurses, for nurses, this is Happy Hour with Bundle Birth Nurses.
We need to have a conversation about birth plans.
Oh, do we?
/ what I would like to say birth preferences, because I think there's a lot of stigma. There's a lot of back and forth. There was just somewhat recently a letter that went out from a certain medical group in New York City that said if you have a birth plan, like not cool, and created a whole lot of viral upset in the birth world. If you saw that, you can find that elsewhere. But I think it's a good sort of prompting for us to have a conversation about birth plans. Let's talk about perspective. I know that you've thrown up some IG polls, and we still have lots of people across the spectrum when they are in the safety of that little IG box to say like, I kind of hate them. No, please be honest. Like, and we're not looking at who says what.
No.
On those, it's just helpful to have that perspective. And so I think as much as to me, the shift in perspective, the shift in culture surrounding birth plans is moving forward towards a more acceptance of birth plans. I think it's important for us to have a little quick conversation and prompt your thinking and spark your brains to consider, how do you feel about it when a patient comes in with a 6-page birth plan? Do you roll your eyes? Do you say, oh, she's not going to have anything right? Or, oh, she's going to be difficult? Or, oh, she must have really high anxiety, right? I mean, a 6-page birth plan, I'm going to go, what's going on here, right? That's going to be a prompt to me instead of judging and writing their story, which is one of the things we say around here as well. Don't write their story. That instead of writing their story, go, curious. Be curious, not judgmental, right? Isn't that like a Ted Lasso? My dad's obsessed.
I'm obsessed too, but I don't know. I think that is fine.
I think it's a Ted Lasso.
Ugh.
Yeah. I feel very
Season
proud of
3 is
myself because
coming.
I never quote TV. So I feel very proud. My dad would be proud. So be curious, not judgmental. And if the quote is wrong, I apologize.
Now that's a new Sarah Levon quote. So.
If it's not a Ted Lasso, it's a Sarah Levon. When we talk about birth plans, I think it's important to understand both sides about why someone might be hesitant about birth plans. What's the issue? And if you're a patient listening to this, you can kind of get the insider scoop about how a bunch of L&D nurses feel about birth plans. Well,
I think, and you probably had a similar case when you were oriented to the unit and birth plans were like brought up, like it's the ticket to the OR. It's just a generalized feeling. And I never really understood it, but I mean, looking back, I'm like, I guess I kind of get it, right? If there's so many restrictions on the care that we can give, they think because, nurses might think like, well, they won't let us start PIT. So they had a C-section. They won't let you get an AROM. So they had a C-section, but it's such a generalization.
Well, and I remember learning, like, I can picture this nurse at my very first nursing job. I was new and just like a sponge and tell me all the things. Okay, great. And patient came in with a birth plan and they were like, oh, okay, so here's the problem with birth plans. And they went on this whole rant, right? Which is an alert to all of us that like for young, impressionable new nurses that our opinions are influential. And I remember like rolling my eyes, just not having thought about it myself to birth plans that came in. And I think there's the component of like, oh, I don't want Pitocin. I want no medical interventions on this birth plan. So then you throw your hands in the air and you go ticket to the OR and then you give up on the patient. And you say, well, she doesn't want this and she needs that. And therefore she's going to have a C-section, And so I think, first of all, this is an alert to all of us to assess our bias. And that could be our bias about a whole lot of things, but particularly related to birth plans. What do you think about it? And you can comment down below and let us know, how are you trained about it? What do you currently think? And what would you need to understand to have any kind of a different perspective? Because I have shifted in my perspective over the years. And especially having worked with patients in the outpatient setting now prior to their births, I think birth plans can be a super effective tool in helping initiate conversations. But to me, part of the problem with birth plans is that, like, if we're working through the old perspective and the old culture that we're trying to change, it's they ask too many questions. That it's sort of that same perspective of, well, I'm just going to tell them what to do. And if they have a strong perspective about, say, PIT, I don't want Pitocin, what do we do as providers? Well, what if this? What if this? What if this? Well, then fill in the blank.
Why did they even come to the
OR.
hospital?
Right, right.
I think too, it's kind of interesting that labor nurses, if you're going to go give birth to a baby, I would bet the majority of us would have a plan. We know
1,000,000%.
We know who we want, right?
Oh, I'd be the worst patient.
We've called the off-duty anesthesiologist to come in the day we're going to be there. Like,
yep.
We know what nurses, and so maybe we didn't have it written down, but we have a plan.
Right. And we know what we want and we know what we don't want. We know who we want in the room, who we don't want in the room.
Exactly. We know what room we want.
Yeah.
We don't want that room. That room's cursed. We want this room.
Exactly. So I think we need to remove it from the paper, and sort of, and think bigger picture here, that from a patient perspective, I had a really interesting conversation with one of my nursing friends who's maybe not the most in love with labor and delivery. She's been around for a while. Justine's smiling because she knows exactly who this person is. She is like the classic, I hate my job. I am traumatized by work. Oh, I never care if I see a birth again, right? And from her perspective, she actually said, I was thinking about it the other day, and like, if I was a patient, if I came in with my birth plan, I feel like it would be like showing that I did my homework. Like, here you go, provider. Like, look, I did the work. I thought about what I wanted. But then you walk in and you get like, birth plan, or like, none of that's going to happen. None of this is realistic. Or like, oh yeah, that's fine. And I think that's the other piece, that like you look through like the quote unquote normal birth plan, that you're like, yeah, it's everything we do. So you're like, oh yeah, like I'll just set this aside. This is just what we do. Versus acknowledging the patient to say like, look at what you did. Amazing. You thought about this stuff. And it's sort of an alert too, that like they've done some work prior, like that she even said for herself, that I would be so bummed if somebody was like, poo-poo on my homework, that like I did my job, what I thought I knew what to do.
That's so true. I love that she had that realization. But I think too, on the flip side of that, we get annoyed at patients that don't do any of the work. Like you haven't done one class.
That's such a good point.
Right? So where's the happy medium? They've done all the work, but they didn't write it down. They've done all the work, but they don't have any preferences.
Right.
Like, which one do we want?
Right. Do you want them coming in educated and knowing how they feel about certain things?
Right.
Because really, that's all it is. It is a tool and a communication tool between them, so they don't have to remember. Think about how hard it is for us to remember all the medical terminology, or like this entirely new obstetric language where they're saying, oh, okay, when I'm learning about erythromycin eye ointment, I learned about it. I can't remember what it's called, the goopy stuff in their eye. And so I'm going to write it down when it's fresh in my mind and say, yeah, I feel cool about that. Or the hepatitis B vaccine, or skin to skin. I learned about skin to skin. Ooh, that sounds so delicious, right? That like I know about that, and I can go through in a practical way and share with you that I did the education and then my feelings about it.
Curious. I'm going to be a little devil's advocate here.
Great.
What about the birth plan that's going around? And I don't know, I have a copy of it in my phone, but I don't know where they get it from, but it's been going around of the my rights over my birth. And it's like it says legal notice on the top, and it looks like a contract. And it says things like, I will not allow any hospital employee to deny me my right to, and it is like pages long. But some of the examples are a support person, to labor in the way I want to, a spontaneous labor, to record my labor and birth, to refuse any unnecessary cesarean, for that you cannot deny a gentle cesarean birth, which if anyone doesn't know, a gentle cesarean would be like skin to skin after. And that's like a lot of pressure I've had.
But is that like pulling the baby out on the sterile field?
I mean, it doesn't say. But I know that, and it even says like here, they cannot deny me my right to leave the hospital and take my baby home if there's no medical issues present, as this is considered kidnapping and is also a crime according to this one's from North Carolina common law, false imprisonment. Like it's very, very scary looking. Okay.
Yeah.
And so my encouragement, I know maybe some people are listening to this have had this come around and it's been going around, could be opposition from the nurse perspective. But I think as what you said earlier, if I got this in my hand, first of all, I know it exists, but I would be like, all right, like I have to be like, I have to be better. In the sense of like, I would have to like put on my A game to build so much trust and
Yep.
so much rapport because there's something that happened
Yes.
that made this patient feel like they needed this legal document to come to the
Right.
hospital. And whether it
Right.
was to them or their loved ones, something happened. They didn't just print this off saying like, oh, this looks nice. Like there was a
Right.
reason.
Right.
And so I think that, we put on our little detective hats as nurses and we have to figure out like, how can we do the best for them without
Yep.
being scared of the ramifications of this
Mhm.
document, without taking it to every single person on the unit and being like, look at this, in a way that just fuels the fire of like, this is not okay, when in fact it's a birth plan. It's just a very
Yikes.
tense one.
I'm scared of this birth plan.
Yeah. And I think that's normal and totally understandable. And it's just remembering to not write their story.
It's sort of the idea that we don't know why, but I'm sure that they have a good reason for it. I did not make that one up. I don't remember where it came from, but I love it because it goes back to that don't write their story. And we're not entitled to their story, right? But just like you said, I'm like, if this comes in, there is fear of the hospital system. They have been told or they have experienced some sort of fill in the blank, and again, I don't want to write their story, but it could be, for the sake of this episode, that it could be abuse, it could be assault, it could be a really poor outcome experience, whatever in the hospital system that affected them so deeply that they feel like they need to be this strong in their preferences, and sort of like alert their care team this much that like they're watching, and I, like I said, I would be very intimidated by this birth plan and I would feel like I'm going to get sued any second. Now, the reality of this birth plan is that they are asking for the same thing. So I think it's easy to see something like this and go like, oh my God, like I am so overwhelmed. I'm going to get sued any second. Like I'm going to do something wrong. And that's, like you said, to me, my first alert would be, I'm going to work very hard to build rapport. I'm going to work very hard to go out of my way with consent and giving so much control in their hands. And let's be honest, continue to offer the exact same care that hopefully you're offering every other patient, knowing that this patient has some sort of story in their background where there is mistrust of the medical system. Now, I would still go through every component and say like, okay, so in the case of a cesarean, is your preference a gentle cesarean? And to me, when we're talking birth plans, there's very intentional language that we can use, that these are your preferences. On my template that I have on my site for patients, it's birth preferences, not plans. We know that we can plan all we want, but it doesn't always go that way. That's why I say flex and flow. But our preferences can be shared. And so I would ask that you as my care team would do everything you can to respect my preferences and help me safely accomplish the preferences that I have here. Yeah. Right. And our responsibility is to, first of all, respect them, understand what they want, and pursue their preferences, right? Just like you as a nurse, I love that comparison, that if I want to be in room 5 and I come in labor, guess what? Everybody on the unit, because they love you and you're a staff, they're going to do everything they can to try to help you get in room 5. And so are we providing the same type of care and respect of the preferences to every patient in that way? I think that is what they deserve. Now, when we're starting to risk safety, that's where sort of like my nurse brain goes of like, okay, but, they're refusing a cesarean at all costs. Maybe it is important to know what your labor laws say, or not labor's laws, what your laws say about who they prioritize based on state.
Right. And by prioritize, it's like, do they prioritize the mother, the birthing person, or do they prioritize the child's life? And that
in California, there's a priority of the mom or the birthing person, and they get to choose that, like, if they refuse a cesarean, you better listen. And if it results in, a demise of the baby, then it does. they
Is
have
that right?
all right to do so. But that's state by state.
So I would like to challenge nurses listening to this that are like rolling their eyes at the beginning of it and like, oh, I still hate them, to maybe approach them differently, being more open to them, thinking of them as preferences than like a solid plan. Birth plans, I would say, are not black and white, right? They'd be gray, and like maybe thinking of it like that, educating in that way. But also, Sarah,
What?
you said a quote that I've always liked that I'm going to share, that when you're explaining birth plans and going over, like, say the patient says she doesn't want Pitocin and like, that's it, I don't want Pitocin. And you ask them, like, can you tell me what you know about Pitocin? And you say the thing of, I want you to refuse out of a place of knowledge, not a place of fear. And I think that's a great line. And do you want to elaborate a little bit on that?
Yeah, I think that we have to understand that patients can refuse anything. And that sort of goes back into that legal document. Like, can they even say this? Yeah, they can. And it's important for us to know, what are the patient rights? We talk about that in the first month of mentorship, right? I have an entire YouTube video on this for patients to understand that they are not fully out of control, that this is their labor birth experience, that they are responsible for every single decision that they make. Mind you, when a patient is refusing something, something in me,
Or I'm going to challenge you, declining something.
Thank you. Fair. When a patient is declining an intervention, or they have opposition to an intervention, or there's resistance to something that is being suggested at the bedside, that it is our responsibility as the medical provider to assure that they understand what they're declining, and not just, oh, fine, they're that patient, right? That our obligation to the patient in a shared decision-making sense is that they fully understand the decision that they're making. And so what's our job as nurses is nursing education. And if the information has not been initially given by the provider, then our job is advocacy, to get the provider in there and say, hey, this patient, is declining this. Do you want to come in and explain why we're making this suggestion? And when you're talking to the patient, it's no problem. I want to hear all about that. And I really would love to understand why you're hesitant about this, or why you're declining this, fill in the blank, whatever the scenario is. My job as your provider is to assure that you are making safe decisions out of education and not fear. So first and foremost, this goes into our patient education on mentorship. I give an acronym ATV, where you assess, teach, and verify, right? And so the first assessment tool is, help me understand why you're hesitant about an epidural, Pitocin, AROT, whatever it is, right? Fill in the blank. And then you listen, and you actually listen to understand, and you're not listening to convince, because they will scope that out so quickly. It's, oh, interesting. Okay, so what I'm hearing is that you believe, or you've heard the education stated, that once you get an epidural, it's a ticket to the OR, that is going to lead to a C-section. Would you be open to some perspective based on my experience and my expertise? No? Okay. Most of the time that's not going to be what's said, right? What's going to be said is, sure, I'll listen, right? And I'm just telling you, I want you, and the reason why I want to explain this is because I don't want you to look back with regret on your labor, right? And in this circumstance, your medical team is making this recommendation because we believe it will be beneficial to you in this way. Ultimately, your decision, and I want you to feel confident in the decision that you make without looking back going, I wish I would have done something different. Explain the rationale, blah, blah, blah. This is why we're making that suggestion. What questions do you have? What concerns do you have? I noticed that like furrowed brow. Tell me more about that, and how do you feel about it? Do you want a second to talk with your support team about it? Do you want to we don't have to make that decision right now. Let's just think about it. That's it. We're going to hang out. We're doing what we're doing. There is no rush in this circumstance, blah, blah, blah. And I know this is really important to you. And so maybe we could bring the doctor back in and discuss some other options, right? Because we're never giving alternatives as nurses. That's really hard not to do when we know there are likely alternatives or other options. But why don't I call the provider back in here? Would it be helpful if I called the provider back in here to discuss XYZ, or see if there might be some other options?
Or get them on the phone if you don't have providers in-house.
Yeah, fair. Yep.
I think too, doing it that way, Sarah, like I think there are some interventions that they tell me their reasoning why. I'm like, yeah, you know what? you're right. Or things like I'm thinking about, like they don't want an FSC and they talk to me about why, or they don't want a Hep B vaccination. And, I think we initially sometimes see these like, no Hep B, like, what do you mean? Like, then you talk to them and they're like, well, I really want to do it at my first PEDS appointment,
Right.
Or I'm doing a different timeline. I'm doing all of them just differently. So it's nice to dig a little more, and then you just feel better about the care you're giving too. And you learn as a nurse.
Exactly. And I think that like very often we sort of were used to seeing things a certain way. And so when it's just different, I think a lot of times we're uncomfortable with different. One of the things I grew up saying, because I grew up overseas, was it's not right, it's not wrong, it's just different. And so often I think in labor and delivery, that's actually a reasonable thing to say, because we're not like, obviously if there's an emergency C-section, you have a prolonged decel, the heart rate's in the 30s, like the right answer probably is to move to the back, right? For safety's sake. But if we're talking like give a Hep B vaccine right now or 24 hours from now, like it's not right, it's not wrong, it's just different, And so even using that as a frame of reference or a lens to look through. I feel like we sort of got off topic, but it all sort of comes back to birth plans and preferences. That the question then is for us to assess, is it okay that our patients come in with preferences? And in order to have preferences, they should have done some education. And if we're weighing the two, that does it feel better that they've done the education and come in with some preferences that we may or may not be able to accommodate? Yeah. And I think part of the art of being an expert labor and delivery nurse is the art of that interpersonal communication and patient education, and having some of these quote unquote tough conversations that to me don't have to be tough if we're not approaching them in a defensive way where it's, well, but, it's okay. I'm open. I'm soft. I'm slow. I sit down. My body language is relaxed. I'm like, I would love to understand why that's important to you. And leave it at that, that we're curious, not judgmental, and that we're actually seeking to understand our patients and then fill in the gaps of their education so that they can make educated, not fearful decisions, and so that we can still at the same time respect their preferences and help them have the birth that they really dream of.
Thank you for spending time with us here during this episode of Happy Hour with Bundle Birth Nurses. If you like what you heard, it helps us if you subscribe, rate, or leave a raving review and share this episode with a friend. If you want more from us, head to bundlebirthnurses.com or follow us on Instagram. Now it's your turn to take what you learned today, apply it to your life, giving honorable, open care to every single patient you care for. See you next time on Happy Hour with Bundle Birth Nurses.